on hepatocellular carcinoma. Thank you.
Well, thank you very much to the organizing committee for the opportunity to be here. I've been to India several times, but this is my first time in this beautiful city. I'm going to talk today a little bit out of the theme of donation to talk about sort of a new area, and this is what we call transplant oncology. And I'm going to use the example of hepatocellular carcinoma as a prototype. So these are the tumors that we are now either approved to transplant or in the development of these indications for transplantation. I'm not going to go over them all because we don't have enough time, but I'm really going to show you in the case of hepatocellular carcinoma, the evolution of our management and what we hope to be able to extract from this example to apply to other tumors. So what is transplant oncology? Well, it is a joining of different approaches to management of liver primary and metastatic cancers. And this involves, obviously, the application of resection therapy and transplant technology, but it also involves the multidisciplinary approach to cancers, including radiation oncology, medical oncology, immunotherapy, and then also the application of immunology, transplant immunology, and tumor immunology to this field. Our first conference on transplant oncology was held in 2019, and the results were published, and people thought this was a very unique idea. But I would just show you that, in fact, in Dr. Starzl's textbook on liver transplantation called The Experiences in Hepatic Transplantation, in the first part chapter, introduction, it stated that liver transplantation was designed for the unequivocal indication of liver replacement originally considered for primary hepatic malignancies that could not be treated with conventional techniques of subtotal resection. So liver transplantation was designed to address primary liver cancer. And in fact, if you look at the history of liver transplantation, the first 7 patients that were transplanted, you can see 6 of the 7 actually had a primary or metastatic tumor to the liver. As you know, through the history of liver transplantation, the early results were not very good. There were a lot of technical issues, a lot of problems with preservation of organs. So patients didn't live long enough to understand the concept of an observation of recurrence after transplantation. But several years later, in 1979, and then in the second edition of Roy Kahn's book in 1987, he describes the King's College experience, the Cambridge experience with treating cancers with liver transplantation. And in the right top, you'll see hepatocellular carcinoma. In their series, they had 46 patients, of which 32 survived for 3 months. Of those 32, roughly half of them developed a recurrence, and as you can see, most of them died. 15 of the 32, the other half, who did not have a recurrence, you can see the majority of those survived. Now, it also shows you in this slide that in the bottom left corner with all the bars, the Cambridge experience initially with the dark color bars were malignant indications. And over time, you can see the white bars are the non-malignant indications begin to increase. And this is because the results of the transplantation for malignancies were not very good. And I could also show you at the bottom right some indications of tumors that could be successfully transplanted. These included things like epithelioid hemangioepitheliomas that have pretty good survival rates. We know now neuroendocrine tumors who do pretty well. And then the tumors that do poorly are those like angiosarcoma and some of the malignant adenocarcinomas that are metastatic to the liver. So the early series in transplantation for HCC, hepatocellular carcinoma, were really quite poor. You can see here the early series, 5-year survival rates were as low as 10 or 15%. And these were unselected. In other words, we just took all comers and transplanted them with livers. And the penalty we paid for that was in the consensus conference of 1983, the NIH stated that primary hepatic malignancies confined to the liver, not amenable to resection, may be an indication, but however, results to date indicate a strong likelihood of recurrence for that malignancy. And for many years after this, almost 20 years, we were not approved to do transplantation for HCC. We had some idea by 1995, however, that if we carefully selected the patients for transplantation with HCC, we could obtain better results. This is a series from Pittsburgh that showed by TNM staging that early tumors, stage 1 and 2, had 5-year survival rates of about 70%. If you had bigger tumors, stage 3, the survival rates dropped to 52%, and those tumors that were stage 4, very large tumors with macrovascular invasion, had very poor survival rates, only 11% at 5 years. And you can see that in this series, more than half of those patients we transplanted were in fact stage 4A. Now, a year later, Vincenzo Mazzaferro from the Milan group, Vincenzo was a fellow in Pittsburgh with us, demonstrated essentially the same finding, that smaller tumors had better survival rates than bigger tumors. And this then generated what we call the Milan criteria, which gives you pretty good survival rates when the tumors are smaller. And in fact, series after this, where tumors were selected to be within Milan criteria, showed 5-year survival rates in the 70 and 80% range. So if you look at the BCLC, the Barcelona Clinic Liver Center staging criteria from 2005, you can see that liver transplantation, shown in the bottom left, highlighted in red, really it was designed for patients with early stage cancers, stage 1, stage 2, and if you had larger tumors, stage 3 and 4, on the right side of the graph, you can see that what they suggested is things like systemic therapy or palliative care. And so liver transplantation in 2005 was really designed for early stage tumors. But we know that HCC characteristics are quite different. Small tumors, large tumors behave differently depending on the background, if they're hepatitis B or hepatitis C. So there are many ways that we can characterize the tumors. I'm not going to go over them all, but we can look at the degree of differentiation, their biologic behavior, such as uptake of fluorodeoxyglucose or PET scan, genomics. We can look at genomic changes, and we can look at other biomarkers like PIVKA2 or alpha-fetoprotein. Now, what we have learned, though, is that we can do therapies directed to HCC to keep the tumors from growing or to get them to get smaller, downstaging. So some of the therapies we refer to as local regional therapies are therapies that we apply directly to the tumor. These are in the form of transarterial chemoembolization, transarterial radioembolization, microwave ablation, radiofrequency ablation, and you can resect them. But what I would like to highlight is the changes in the systemic therapy. So first, we talk about local regional therapies. These are some early series with transarterial chemoembolization, transarterial radioembolization. And you can see that if the response rate ranges from 22% to 85%, if those patients do respond to downstaging, their 5-year overall survival rates are very similar to what I showed you before with Milan criteria. These are out of Milan criteria patients that are downstage. Their survival rates at 3 to 5 years, very similar to those patients within Milan criteria. We have been working with a concept of radioembolization. Instead of giving chemo embolized tumors, we are giving radio small microbeads into the tumor. And this study shows that using radioembolization with yttrium-90 can downstage the tumors faster, more completely, and get these patients transplant or into a transplantable situation, T3 to T2 staging, downstaging, almost twice as much as chemoembolization. These yttrium beads give off a beta particle and a gamma radiation within 2 millimeters of the beads. They are very effective at reducing the tumor. They are tumoricidal, and in this series of patients collected multi-center, they found an overall survival rate of 87% in patients with HCC. Generally, we believe most of these patients without treatment would die within a year. And if they were able to be resected or transplanted, they had a 93% survival rate. And as a result, the FDA approved this therapy for patients with HCC. Now, more recently, we've also been using radioembolization or radiotherapy, be it SBRT, external beam radiation, with combination of other approaches to stimulate the immune system. So what we have found is that radiation induces tumor cell death. It liberates tumor antigens that upregulate the immune system. It enhances T cell adhesion molecules within the microenvironment. It attracts T cells and upregulates cytokines that stimulate the immune system. So many papers now have suggested that radiation therapy enhances immune regulation, and in this study from Singapore, Brian Groh's group demonstrated that the combination of radiation and induces upregulation of T cell subsets that enhance tumoricidal behavior. So we have combined that with immune checkpoint therapy now, which enhances T cell responses, and we have shown that nivolumab, for example, ipilimumab, in the setting of SBRT, can enhance the survival rates of patients with HCC. And here, just to show you, in red are patients who got nivolumab and ipilimumab with SBRT compared to those patients in blue that just got nivolumab. And you can see that progression-free survival, hepatic freedom from progression, and overall survival rates enhanced in the patients who got combination therapy. So what we're looking now is the new BCLC that just was released in 2022 now includes systemic therapy with immune checkpoint inhibitors as frontline therapy. And now you can see on the advanced stage 3 and 4, the use of immune checkpoint inhibitors actually will enhance the downstaging of what we're doing, and what we're hoping now is to be able to transplant these patients safely. I will just mention that we also have approaches to enhance the anti-tumor effect of our immunosuppression. The use of mTOR inhibitors, everolimus and rapamycin, enhance patient survival by decreasing HCC recurrence. This is an old study that shows that patients on everolimus with HCC had a better survival rate than those that did not. And this was validated in the Silver study, which was a European study that showed patients getting sirolimus had a better survival rate. And in a registration study, we also demonstrated that patients outside Milan criteria with everolimus had a 6% two-year recurrence rate versus those that did not get everolimus at 23%. So just to conclude, to give you some picture of where we are, we know that liver transplantation is an effective therapy for patients with unresectable HCC, but we're also now showing that we can do patients selected with metastatic tumors to the liver. We're looking at a combination of tumor genetic profiling, looking at personalized medicine in the field of transplant oncology, and as it relates to the theme of this meeting today, we really are limited by organ availability. And so using living donors as an option, using enhanced expanded criteria donors is really where liver transplantation for cancers will be headed. Thank you.